Organissima, New York. Your exotic skin, hair, and beauty source, and your one-stop shop for all your natural and organic skin and hair care, featuring authentic organic Moroccan oil and prickly pear seed oil and much more. Bringing you only the best, straight from the source and proudly produced in the USA. So what are you waiting for? Shop today. Organissima, New York. Your beauty is our duty.
Folks, welcome back to the iHealth channel, iHealth Radio. We're your host, Hurricane Age. New day, new show, new topic. Great topic, must-watch topic, perfect timing topic. We are in the pretty much the last days of June, and that leads into July, which is Fibroid Awareness Month. Uterine fibroid discussion is a must. And with me today, I have a specialist who actually is a doctor that treats this, that works with this, that provides awareness on this. And so without any further ado, I have with me Dr. John Fisher from the Fibroid Institute of Houston. Doctor, welcome to the show.
Thank you, Hurricane. Appreciate you having me.
Oh, my pleasure. I know you and we met a few months back. It's last year. And we had a brief discussion. I saw you in action doing your work in the community, doing, the awareness part. And I was personally impressed. You had a nice setup, and you were there by yourself and doing the work. And that was something exciting to see. I love that. Personally, I just want to thank you for doing that, because there are different types of doctors out there. Not everybody is willing to actually go in the community and do the work and deliver and provides the instructions, or at least the guidance and the education live. And you're doing this as well. And I have to thank all the doctors actually that come on the shows, because that's what they're doing. Their mission is not only just to provide service, but also provide education to the world, and specifically to the folks in their communities. So, Doctor, welcome.
Thank you. I appreciate that. Yeah, I've always taken a very personal approach to fibroid embolization, or treating uterine fibroids with embolization. I think education is a very strong component of any medical procedure, but especially this one, because a lot of women don't know about their options. And, there are just so many options, including uterine fibroid embolization, the procedure I do, but a lot of other options out there. So it's just a matter of educating. And I think as physicians, most of us do a really strong job at treating, either through medication or procedures or surgeries. But where I feel that many of us fall short is on the educational part and really informing patients. And I've always taken a very personal and very heartfelt approach to education and educating patients and outreach in the community.
Again, I commend you for doing that. That is the highest level. And you're delivering services, you're delivering, information and educating people about this whole thing, right? But so I know I have a question that I just need to get out of the system here. Why specifically this specialty? And is it like an OBGYN, concept?
So it is a gynecologic problem. Uterine fibroids are just benign muscle tumors of the uterus, and they are extremely common. It's estimated that 70% of all women will have fibroids at some point in their lives. Actually, over 80% of Black women. So the African American community is disproportionately affected by fibroids. Fortunately, the vast majority of women with fibroids never know that they have them, because they never cause any symptoms. But about 25% of women develop symptoms. The symptoms can be quite debilitating and really alter a person's life and ability to do normal activities and normal things, and having to plan their day around some of their female issues. So, I'm actually not a gynecologist. I'm what's called an interventional radiologist, which I think my own mom probably can't even explain what it is that I do. But interventional radiology is a very cutting edge specialty that is basically image guided, minimally invasive surgery. So when I was in the hospital, and I was at St. Luke's Hospital in the Texas Medical Center for 21 years, and while there, I did all kinds of procedures. But the common denominator to all of the procedures that we do in interventional radiology is that we don't cut patients open to do them. We do them through minimally invasive means, and we use image guidance, whether that be X-rays or CAT scan or ultrasound or MRI, to guide those procedures. Because since we don't cut patients open, we have to be able to see what we're doing. And so uterine fibroid embolization is one of those procedures that I did. It's really been a passion of mine since the very early part of my career. It's something that I've really had a special interest and special expertise in since I did my first case 23 years ago. And so while I did a lot of other things when I was at St. Luke's Hospital and on faculty at Baylor College of Medicine, this has always been my niche, what I really enjoyed doing. And I just find it very gratifying because of the success in treating patients with this technique. It's really become a passion of mine. So it really got difficult to provide the type of care, efficiency of care, really overall quality of care. It got more and more difficult to do in the hospital. That combined with the evolution of the procedure to where we could do the procedure completely outpatient out of the office and send patients home the very same day, just a couple of hours after the procedure, really prompted me to start this practice, which was a little less than a year ago, about 9 months ago. And so now I think that we're able to do much better than we've ever been able to do for patients. And that's really what it's all about.
Doctor, I have to say, I mean, to be honest with you, the closest, I'm in healthcare as well, and the insurance, and we obviously OBGYN, concepts are part of what we cover insurance. So we have doctors, we have nurses. I've worked also in a hospital settings, so it's and again, I'm surrounded by women in my family, so my mom, my daughter, my wife, and so it's always important to know these things as a person, and also as a just in a career path, right? And fibroid is not something, or uterine fibroid, it's not something I've actually was made aware of, known of. And to your point, I haven't heard my wife talk about it, or even people around my circles talking about it. I don't even remember seeing a clinic other than the first time seeing you. So is that a common practice?
Well, like I said, uterine fibroids are very common, but patients often don't feel comfortable discussing it with family, friends, some of the female problems. So it's not always, some do, but many do what we call suffer in silence. And they may discuss it with their gynecologist or their medical doctor and their primary care physician, but they may not like the options that they're given. I mean, historically, the treatment for fibroids is a hysterectomy or open surgery, what we call a myomectomy, where they remove the fibroids from the uterus but leave the uterus behind, or a hysterectomy where they remove the entire uterus. And so many patients don't like those options because of the recovery time associated. Many, women can't be down and out of work or out of their normal daily routine or activities for 4 to 6 weeks during recovery from surgery. So this is an option, a less invasive option that is a very good option for many, not all patients, but many patients, that offers a shorter recovery time, less invasive means, so no scars or incisions, surgical incisions. So it's a very attractive option. But the challenge, since I started doing this procedure 23 years ago, and I've done thousands of these procedures, over 3,000, is always been to educate the public. And like I said, I've always taken education very close to my heart. And that education is on two levels. It's educating the general public and women about their options, so that more and more know about not only the uterine fibroid embolization, but other less invasive surgical means for treatment of uterine fibroids. And at the same time, educating some of my referring doctors, both gynecologists and primary care physicians, about, who benefits and who may not benefit from this type of a procedure. So education is really a two-pronged thing. It's at the physician level, physician to physician level, and also direct to the public and women who may suffer from fibroids, so that they don't have to suffer in silence.
Well, thank you, doctor. So a few things. I know you mentioned they're kind of ulcers or tumors, right? If now, those, I'm assuming, benign and not malignant, or can they turn into like cancerous, and more dangerous levels?
So, uterine fibroids are just benign muscle tumors of the uterus. Okay, there are very, very rare reports of malignant degeneration of fibroids, but most people will go their entire career and never see this. But it is, at least in theory, possible and has been reported. But the vast majority are just benign tumors of the uterus. So they don't cause any trouble as far as like cancer, but the symptoms that they can cause can be quite debilitating for women. And so I'm happy to review some of those symptoms, or at least the common symptoms, so patients know what to look out for. But
that's my next question.
Sure.
What are we looking for here in terms of symptoms?
Sure. So, when a woman, like I said, most women with fibroids never know that they have them. They may be diagnosed incidentally when they have a CAT scan or an ultrasound for another problem, or many times patients are diagnosed when they have their OB ultrasounds when they're pregnant, and their doctor will say, hey, you have a small fibroid or benign muscle tumor in your uterus, but they're not causing any problems. So, if I like to say, unless fibroids are bothering a patient, we don't bother them. So we don't treat asymptomatic patients. And I've always said it's very hard to make an asymptomatic patient better. So generally speaking, if they're not bothering a patient, we don't treat with embolization or really anything else. But common symptoms that patients experience as a result of fibroids, the natural history of fibroids is that they tend to grow slowly over time. There are exceptions to that, like when the hormone levels are higher, as like during pregnancy, or if a patient's taking exogenous hormones, they can grow at a much more rapid rate. But typically they grow maybe a centimeter or less, slightly less per year. And the larger the fibroids get, the more symptoms they tend to cause. And so when a woman starts experiencing symptoms from her fibroids, those fibroid symptoms usually fall into one of two categories. There are the bleeding symptoms, which are heavy menstrual cycles, prolonged menstrual cycles associated with very heavy flow, oftentimes in blood clots, and in more severe cases, resulting in anemia or low blood counts, and in very severe cases, even the need for a blood transfusion. Fortunately, that's fairly uncommon, but not as uncommon as you might think. And then the other types of symptoms that fibroids can cause are related to the size or the weight or the density of the fibroids. Since fibroids are made of muscle tissue is a very heavy, very hard, very dense tissue. So as the fibroids grow, or even if you get multiple smaller fibroids enlarging the uterus, it's much like when a woman's pregnant. So the enlarged uterus or the big fibroids start pushing on all the other structures around it in the pelvis, and can cause things like frequent urination, pelvic pain, pelvic pressure, back pain, constipation, painful sex. There's a lot of what we refer to as bulk symptoms. And then many patients have both bleeding and bulk symptoms, but usually one or the other kind of predominates in most patients. So, but, we can treat both bleeding and bulk symptoms successfully with this procedure, again, in properly selected patients.
Thank you, Doc. So I want to go back to I know you answered the question about the cancer, which is an awesome response. In fact, that it's at least not as bad. And there has been cases, but to your point, the general matter is that this is not as malignant, so it's not as dangerous, but it is definitely painful. Definitely something that someone should, I guess, take care of and eliminate if they could, and hopefully with a procedure that's less invasive and no surgery involved. Because when you mentioned, taking off the uterus as a solution, that sounds pretty brutal. You hear that in oncology, but you don't hear in more benign stuff. And so I just wanted to address that part, because you don't have to go through that, immediate. I'm not a woman, but I have actually known women who have done those procedures where they had to remove the uterus, and that is not a fun experience to hear it from them, or at least to see them going through that process.
Sure, yeah. Hysterectomies are very common. It's they're a very common surgery. They're done for various means, but fibroids are a very common reason why patients have a hysterectomy is related to fibroids and the symptoms that they cause. And, it's still the best answer for some patients. But like everything, including the UFE procedure, it's, surgery is not for everybody. And so, and it is a major surgery with a significant, at least 4 to 6 weeks complete recovery time, as I mentioned. So, the good news is that patients have more options today than they've ever had before. And there are less invasive surgical techniques that I don't do, but I've come to know a lot about through my gynecologic colleagues. There are better drugs and medications out with, both hormonal and non-hormonal to control symptoms related to fibroids, both the bleeding and the bulk symptoms, with more medications coming out all the time. There are, all kinds of options, and options for patients are always good, but UFE and uterine fibroid embolization is just one of the many options. And so it's a matter of, picking the right option for the right patient. Like I tell patients all the time, the way I view this is I just view it as all of these options, both the UFE procedure that I do, the less invasive surgeries, the drugs and medications. I just see them all as tools in the fibroid toolbox. And, it's like going to your garage. You don't go to the garage and grab a hammer for every job around the house, right? We grab the right tool, the one that's going to give us the result that we're looking for. And so it's much the same approach, is that I realize not one option, including my own procedure, is the best for every patient, but many patients it is. And the good news is that patients do have options. And so that's why I feel that the educational part of this is so important, because the more a patient knows about the different options, the better decision she can make for herself. And that's something I feel very strongly about.
Well, I appreciate that, Dak. And you know what? It is important to point to know all your options at all times. And we do that in everything in our lives, right? And health
Right.
is the most important one. And we definitely want to know what's available out there. And again, lack of education can limit, those options. And therefore, you might just go to the first thing, could be surgery, and it may not be the ideal one. And the sad part would be like to do a surgery and eventually find out you could have done it without it, and that would be like a very not happy outcome in terms of your psyche and your relationship and life and everything. So that could be very detrimental. So it's important. So doctor, you talked about the different types of symptoms. And now, are they types of fibroids, or specific types? Or are they all?
Sure. So there are certain types of fibroids categorized primarily by the location in the uterus. So some fibroids are like on the inside part of the uterus, maybe even bulging into or maybe sometimes completely contained within the inner cavity, or what we call the endometrial cavity of the uterus, which is the inner cavity of the uterus where the baby grows, like during the pregnancy. And then there are some fibroids that are completely contained within the muscular wall of the uterus. So those are what we refer to as intramural fibroids. And then there are certain fibroids that are more on the outside part of the uterus, and we refer to these as subserosal fibroids. And then there are fibroids that actually hang from the outside of the uterus by a stem or a stalk, much like a cherry on a stem, so to speak, and we call these pedunculated fibroids. So yes, fibroids are characterized or categorized primarily by their location in the uterus, and the location really makes a pretty significant difference in the types of symptoms that they cause. So any fibroid that is associated, touches, contained within the inner cavity or the endometrial cavity of the uterus is much more likely to cause heavy bleeding. And they don't have to be very large to do so. And that makes sense because it's that inner cavity lining that is sloughed off every month during a woman's menstrual cycle. Fibroids that are within the wall of the uterus and not associated with the cavity or on the outside of the uterus, they can cause heavier bleeding as well, but more indirectly because fibroids tend to be very vascular, benign tumors. And so they tend to draw a lot of blood into the uterus. And the more blood that there's available, the more potential bleeding during a woman's monthly cycle. But typically the fibroids within the wall or on the outside are more likely to cause the bulk symptoms that we talked about, the pelvic pressure, pelvic pain, frequent urination or urinary symptoms, urgency. But so there is, this categorization of fibroids based mostly on location. And not only does it, predetermine many times what types of symptoms the fibroids are more likely to cause, but as it's one of the very important things that we take into account in determining what the best treatment option or options are for any given patient. Size, number, location of the fibroids, number of fibroids within the uterus. These are all very important things to look at.
So, doctor, you alluded earlier that one of the times where they're discovered is during pregnancy, for example. Now, do they cause any risk to a pregnancy for someone who may be expectant?
It's a great question. And the short answer is yes. Fibroids can lead to higher rates of miscarriage or lost pregnancies, especially the ones that are, again, associated with that inner cavity where implantation occurs of the embryo. So anything that interferes with that implantation or, kind of early development of the fetus can result in a higher risk of miscarriage. So certainly certain fibroids can cause higher risk of miscarriage. Large fibroids, even if not associated with the inner cavity, can also affect a pregnancy just because of their size and, pushing on the fetus and on the uterus. So they can indirect in that way. So yes, fibroids can affect pregnancy in those ways. But there are majority of women with fibroids, that are discovered at the time of pregnancy have a fairly uneventful pregnancy. They deliver the child without a problem. They can also affect delivery. That's the other part that they can affect in terms of the fetus's ability to pass for a vaginal delivery. But all of these are possibilities, but I think the majority of women with fibroids that are diagnosed incidentally at pregnancy, their pregnancies go fairly unremarkable, don't have any issue with the fibroids. But it's a very common story that we hear, since fibroids are hormonally dependent and tend to grow more quickly during pregnancy, it's not an uncommon story that we hear a patient say, I never knew I had fibroids. I had the obstetrical ultrasound or sonogram at the time when I was pregnant. They said I had a fibroid. It grew fairly rapidly during pregnancy. I had my child, everything went fine, delivered my child, and boom, now all of a sudden I have all of these symptoms. So that's a very common story.
So doctor, you mentioned earlier about I guess the African American community or Black community as having a higher risk. Is there a genetic predisposal to having fibroids? Is there an age group that is actually more at risk than other?
Sure, absolutely. There is 100% a genetic component to fibroids. So if a woman of any race, if her mother or sister or first degree relative has had fibroids, she's at much higher risk even than the general population of having fibroids. And like I said a moment ago, it's estimated that 70% of all women, regardless of race, have uterine fibroids, but a majority, fortunately, remain asymptomatic. But yes, the Black or African American community is disproportionately affected by fibroids because they're 80% or greater. Again, majority remain asymptomatic, but it's a problem for all women, for sure.
But how about age? I mean, you mentioned that women can have the whole life and they can have them, but asymptomatic, so nothing is clear. But is there a particular age where that is more, a higher risk or higher percentage of the population that does, I guess, show with symptoms?
Sure. While fibroids can develop earlier, I've seen women in their 20s develop fibroids. This is relatively uncommon for a 20-year-old to have significant symptoms related to her fibroids. The majority of fibroids that we see, especially those that are asymptomatic, are women in their late 30s or 40s. That's kind of the peak age group, maybe 35 to 50. Fortunately, after menopause, when a woman reaches menopause, which every woman's different. Some women go through menopause earlier, some later. Again, there's a genetic predisposition to that age. But the average age of menopause for most women is early 50s, maybe 50, 52. So when a woman goes through menopause and her hormone levels or estrogen levels shrink, the fibroids will shrink and die on their own. So, and new fibroids will not form, in part because they're dependent on the hormones to develop and to live. So menopause is a process. And so during that menopausal process, which can take months, maybe even years for a woman to complete, fibroids can remain symptomatic, but eventually they will shrink and die on their own, and their symptoms will go away after a woman completes menopause.
So you talked about hormones as a key trigger. Now, for someone who has thyroid issues, and it's pretty common, would that increase or decrease the chance of having fibroids by any chance?
Thyroid hormones, no effect necessarily on fibroids. It's more like the female hormones, like the estrogens, things like that, not thyroid.
It's not metabolic, stuff. It's really just the female, hormone specifically.
Correct. Okay. Which is why they tend to grow more rapidly when the hormone levels are high, like during pregnancy, or if someone's taking exogenous hormones or hormone replacement. And the same reason why they shrink and die on their own after menopause when those hormone levels go down.
Then let's talk about the big elephant, I guess, in the room. I mean, with I guess that I guess in today's society, sex is a predominantly a regular activity, and there are a lot of means of, I guess, precautionary means, against pregnancies, and there's a lot of pills with hormones based, and even there's like the what do you call it? Other means that actually prevent, such as I forgot the name now.
Like IUD?
IUDs, there you go. So the IUDs with hormones. I mean, that's another one. Now, it seems that those are pretty much can literally have a direct impact on having fibroids. And so would you recommend those or not recommend them based on the outcomes? I mean, again, it's a question that someone's going to ask, and especially if they do utilize those.
That's a great question. There's a give and take or a push and pull with hormones and fibroids. So you're absolutely right. Depending on the formulation of certain birth control pills with high estrogen contents and things like that, they can certainly lead to more rapid growth of fibroids, certain hormone replacements, and so forth. On the other hand, one of the treatments for fibroids and helping to control symptoms are something as simple as hormone therapy, like a birth control pill. Usually something with a lower estrogen level, but can be very effective in reducing symptoms in some patients, and is oftentimes the first line treatment that a patient may be placed on by her gynecologist. IUDs can be, especially those that have hormones in them, can be used to help control symptoms, the heavy bleeding related to fibroids, and can be quite effective in some patients as well. So these are all kind of early treatment options that many patients have. When I said earlier that drugs and medications can control symptoms, that's where the hormones falls. There are all types of hormones, from oral, like I said, simple oral contraceptive type hormones that can be used to control symptoms, all the way to more aggressive hormone therapy with GnRH agonists, which are shots like Lupron or Depo-Provera, that can basically induce a pharmacologic menopause in a patient, and can be very effective in reducing fibroid growth and promoting the shrinkage of fibroids, and reducing their blood supply. But the effects of most of the drugs and hormones and medications, most of the time they are temporary. So that's one of the downsides is, many of these things can be used for some period of time, but many, as soon as you stop whatever treatment that you're doing from a, hormone or drug level, most of the time the symptoms will return. So it's for those reasons that the hormonal therapies, the medication therapies, tend to be more temporary solutions or stopgap type solutions to help control a woman's symptoms until we can figure out a longer term solution. And then many hormone therapies, not all, but many, especially some of the more aggressive ones, have significant side effects, some of the menopausal type symptoms, so that aren't real pleasant for some patients as well. So, again, I tell patients all the time there are pros and cons to every treatment option. You can't get away from that. So it's just a matter of trying to pick the best treatment for each patient, which has the most advantages and the fewest disadvantages and the lowest risks. And that's really what we're setting out to do each and every time we sit down with a patient. And if they're a good candidate for the fibroid embolization procedure, that's fantastic. But if they're better treated with something else, I'm going to tell them as much. So.
Well, yeah, but doctor, I thank you for breaking it down. I mean, I love it. I mean, we have the whole picture, but the concept is that it sounds like those are like symptom, treatments, or just kind of you can live with it as long as you have a treatment. You don't feel it. It's like having a Tylenol for your headache and or pain, and you kind of bypass it and you'll feel good. But it's not really taking care of the real problem. I mean, ultimately, a solution would be to eliminate those fibroids, and therefore
Correct.
either surgery or to a minimum invasive, solution such as your procedure, and those would be like the outcomes that probably would be more, ideal. But people have to make that choice, of course.
Right. And it depends on many factors. Again, there are a lot of things that we look at. I mean, how severe are patient's symptoms? How old is she? What future fertility desires that she has, what, if any, other medical problems that she has, what's her surgical risk? I mean, there are just so many factors that we look at in trying to make that determination. It's not a one size fits all, that's for sure. But like I said earlier, the good news is that patients have many more options today than they've had in the past, and options for patients are always a good thing. It's just that, and it's not necessarily the fault of physicians in general. I mean, everybody's stretched for time. Everybody doesn't have the time necessarily to spend with patients to educate in the way that I really feel like that we should. It's one of the things that I love about my current position and practice is, no longer being in the hospital and pulled 5 different directions. I feel like I really have the time needed to spend with patients to really explore their symptoms and explore the different pros and cons and explain and educate. And that's, like I said, that's a very important part of all of this.
Thank you, Doc. And by the way, again, when I met you, it was a weekend, so you actually do, what most other doctors probably would not do. Because to your point, they're probably called into hospital settings and things like that, and you're doing that on an additional time, which is again going beyond the call of duty to make it happen. And you are providing the education. So I want to go back to one question. We talked about risk for pregnancy, but what about risk for fertility? Is there a link to that?
Sure. So you mean fertility as a result of fibroids, or as a result of the fibroid embolization procedure that I do, or both?
I guess both. You went ahead on the other one, but that's good.
So yes, I mean, fibroids can affect fertility by the ways I stated earlier, by interfering with normal implantation and early growth of the embryo or fetus, and can lead to higher risks of miscarriages. So that certainly can affect certain, again, the ones typically on the inside lining of the uterus, the submucosal fibroids, the intracavitary fibroids. And then as far as our procedure, so there are just some unknowns with uterine fibroid embolization in terms of future fertility and pregnancy. So if a patient has a desire to maintain or potential desire to maintain fertility, we just have to be on the same page and have a discussion about what we do and what we don't know about future fertility and pregnancy after a UFE procedure. And what we do know is that it is very possible to get pregnant and have a normal child, normal pregnancy after a UFE. It's been reported hundreds of times in the medical literature. It's probably thousands more cases that have not been reported, including quite a few of my own patients over the years. But what we don't know is whether there's any increased risks of infertility, complications of pregnancy, birth defects, any of those sorts of things in a pregnancy after a UFE procedure. And no one's ever shown that there are. No one's ever shown that there are not. So that's why I'm saying there's just some unknowns. So again, those factors are an important part of our determination on which patients are a good candidate for our procedure, which patients are better served by something, another treatment option that we don't do, that their gynecologist has to offer. So it's all part of the determination and a very important part of that.
Thank you, Doc. Now, you talked about the symptoms and what they look like, but now if someone doesn't have any, should they be looking to just double check to make sure that they've not? Because early prevention is like everything else, right? You want to be detecting things before it's too late. If you're having symptoms, you're already like at a different stage. What is the recommendation there?
Well, like I said, we don't treat patients who are asymptomatic. So routine screening is really not really indicated or something that we recommend or that's necessary. But, it's important for patients to understand the types of symptoms that fibroids can cause so that when they start having these symptoms, they can recognize them early because generally speaking, the larger the fibroids get and the larger the uterus gets, the fewer treatment options are available to a patient. So I encourage patients, the best time to be treated is as soon as you start having significant symptoms, because it's at that point that you have the most treatment options available to you. At some point, the fibroids or the uterus get so large that the UFE procedure, the less invasive surgical options are all off the table, and your only option is open surgery or traditional surgery. And that's why it's so important to educate so that we get, the options out to patients that are, suffering in silence because they don't like the initial treatment options that they were offered.
I was going to ask like how big those things can get. I mean, I'm assuming, if people don't pay attention, I mean, think about it. Some people, they realize they're pregnant, in 60 days later, right? Whatever. And that could be time to grow something big enough that you might confuse and that could be a challenge.
Yeah. I mean, fibroids can get quite large. The majority of fibroids that we see and treat are between 1 and 10 centimeters. We can treat fibroids a little bit bigger than that, but between 1 and 10 centimeters is probably 90+% of what we see and treat. But fibroids can get, the size of basketballs. They can get quite large. And 10 centimeter fibroid is roughly the size of like like maybe a small cantaloupe or a grapefruit, something like that.
That will definitely stand out. It's at that point it's going to be now, and you can still treat those with the minimal, with UFE.
Yes, at 10 centimeters, that's definitely at the higher end of what we treat, but still treatable. Again, depending on a patient's symptoms. But it's not just the UFE procedure that's limited by size. It's some of the less invasive surgical options that I haven't really talked in detail about, but there are some newer, less invasive surgical options for treatment of fibroids. So things like robotic surgery, laparoscopic surgery, where they make puncture holes in the abdomen. So they're smaller incisions associated with a much shorter recovery time, rather than 4 to 6 weeks total recovery. It's about half that, like 2 to 3 weeks for most patients. And they can do hysterectomies this way, where they remove the uterus laparoscopically or robotically. They can do it myomectomies, where they cut the fibroids out. They can do it robotically, laparoscopically, or even hysteroscopically, which is a transvaginal approach without any incisions at all. So again, at some point, the fibroids reach a size where none of these are options anymore, and the UFE is not an option. And unfortunately, at that point, the only option is open surgery. So it is important that as soon as a patient, recognize the symptoms and get treated early on, as soon as they start developing significant symptoms, because it's at that point that they have the most options available to them.
Thus, the importance of education, because if you don't know, you're not going to know until it's too late. So we want to make sure people are aware.
So I don't know how many of your listeners actually know what UFE is, or what uterine fibroid embolization is. So I kind of talked about it very generically, but I'd love to go through some more details of the procedure.
Sure, please.
So embolization is just a fancy name that means cutting off the blood supply to something. So when we do uterine fibroid embolization, in summary, what we're doing is we're just going inside and cutting off the blood supply to the fibroids, and we cause them to shrink and die. In a nutshell, that's what we're doing. And the way that we do that is not by cutting a patient open to do it, but we work through tiny puncture holes. But since we're attacking the blood supply, we first have to gain access to that blood supply. And we do that through a tiny puncture hole into the artery, not even big enough for a stitch. It's just a tiny little puncture hole. And usually we're doing that through what's called the radial artery, which is a tiny puncture hole in the left wrist, like right here. And historically, we've done the procedure through the femoral artery, much like a heart catheterization type procedure, which is the artery at the top of the leg, kind of where the leg meets the body right there in that crease. And so we still do some that way as well. I really give the patient options, and like everything, there's pros and cons to both. But when we talk through those options, most patients prefer the radial access, which is kind of the newer technique. Tends to be more comfortable, allows patients to get up and move around faster after the procedure. But we can do it either way, and I've done many both ways. But once we gain access to the blood supply, whether it be through the wrist or through the top of the leg, we use an X-ray camera to guide a tiny, tiny tube through the arterial system and into the blood supply to the fibroids. And once we have the tube within the blood supply to the fibroids, we inject these tiny little particles. We use two different types. We use Embosphere and PVA, or polyvinyl alcohol, and we inject these tiny particles into the blood vessel feeding the fibroid or fibroids. And these tiny particles get carried by the blood flow into the smaller and smaller branches of the arteries feeding the fibroids until eventually they reach a tiny blood vessel that is smaller than they are. So these tiny particles get stuck. They're too big. They can't go forward, so they don't circulate in your body. That's a very common question. They get trapped in the fibroids, and they block off all the tiny blood vessels feeding them. So that's how we shut down the blood supply to the fibroids, is by infusing enough of these tiny particles that it blocks off all the blood supply to the fibroids. The procedure is done as an outpatient procedure. We do the procedure at our office in Katy. We have other clinics around town that we can see patients in, but all of our procedures are done in Katy. The procedure usually takes about 1 hour. During the procedure, we have a full-time CRNA present who will provide a deep IV sedation for patients, so they won't remember any part of the procedure. So it's very comforting. And then as soon as the patient wakes up from the anesthetic and their puncture site looks good, they go home. Typically within an hour or so of the procedure, they're on their way home. So, and we can do this very efficiently and very effectively for many patients. But that's how we do the procedure basically. And then over time, over the course of several months, the fibroids will shrink an average of about 50%, and they also change in their composition. So fibroids are made of muscle tissue, and muscle tissue is a very heavy, very hard, very dense tissue. So after we embolize them, not only do they shrink, but they change from that heavy, dense, hard muscle tissue to a much lighter, softer, spongy type scar tissue. And so the combination of the reduction in size of the fibroids and their change in their composition is what leads to symptom relief in over 90% of patients. And then patients go home, have very few limitations, and they completely recover within about 7 to 10 days, or about 1 week after the procedure. They're completely back to normal and back to their normal activities.
Wow. I mean, it's marvelous. I mean, I was like literally picturing the whole thing, like doing a visual effect in my brains here on, I mean, I would love to see a 3D, like, one of those 3D demos of it, going through it. Maybe there's one out there. I don't know. I'll have to find one.
You can find it. There's some 3D like kind of animations.
Yes, exactly. On
YouTube. They're out there.
All right, good. So I'll attach it. That would be cool to show people. But doctor, thank you for breaking it down, because I mean, the one thing you mentioned, you said sedation. So they're not fully under an anesthesia, status where they're intube and all the stuff. It's more just where you're kind of groggy, you don't know anything, and then you just wake up. Am I getting that right?
Exactly. It's not a traditional general anesthetic where you have a breathing tube or you're on a breathing machine. They're breathing on their own, but they're sedated enough that they won't remember any part of the procedure. So it's just a deep IV sedation, much like they provide for endoscopy or colonoscopy. It's very much the same.
All right, perfect. Again, and sometimes that's a big question. Like, oh, I don't want to go under, and people are afraid and whatever. When you hear that this is not that kind of thing, people are probably more open to the procedure at any given point.
Sure.
I mean,
Sure. And in returns, in regards to recovery time after the procedure, as I said, the average complete recovery is about 7 to 10 days. I can tell you that the hardest part of the entire process or procedure, historically, what's been the most difficult symptom to control after the procedure has been the pelvic pain that many women have after embolization. I have patients tell me all the time that this pelvic pain kind of scared them away because they get online and they read about all these patients' experiences with severe pain after the procedure. Now, the pain is really just the body's natural response to cutting off the blood supply to the fibroids. It's the body's warning signal, so to speak. It's the same reason that patients with heart attacks, when the blood supply to the heart gets compromised, they get chest pain. And so it's much like that. And every patient's different. So some have more severe pain, some have less severe. But in general, majority of the time, the pain can be fairly significant for most patients. Now, when I was doing the procedure out of the hospitals, we would, the traditional way of doing the procedure was to admit every patient overnight for pain control and give them high doses of narcotics, maybe put them on a pain pump, and then send them home the next day on a variety of pain medications. But we have some unbelievable cutting edge pain control techniques that we're using so that most of our patients go home an hour or so after the procedure pain-free or with very, very mild pain. And most don't even have to take any narcotics, oral narcotics at home. And even those that do have to take a narcotic here or there, it's usually just very sporadic. So, I encourage patients, if you get online and read about the procedure and you read about some of the pain that patients report, our patients don't have that experience. And it's because of these cutting edge pain techniques, pain control techniques that we use. And really the procedures evolved to a point where, patients still have some pain, but it's nothing like historically what we've had to, what they've had to deal with or what they've had to face.
well, technically, I mean, it's still they come to you for a solution from severe pain and all these other symptoms that actually created that in the first place for long term. So this is a temporary, and eventually it goes away. And I love what you said. I mean, I think I love the way you clarified it, that your procedure and the way you do it, it's really eliminating most of that, and therefore it's a lot easier. So it makes people feel at ease, and so that's important to hear. I mean, that's a big deal for a lot of people.
Yeah, and it's a big differentiator between what we do and what others out there doing this procedure do. Is that our pain control techniques are second to none. I've never seen any work as well.
So, doctor, you are located in Houston, Texas, and you do have another facility in Dallas. Now, I'm assuming you can receive people from all over, to your facilities. I mean, they can come. I'm sure you're getting them from different states as well, where, they might not have the same procedure or at least the same access. One of the questions that typically is always, at everybody's mind, these are, I guess, electives, right? And so,
Right.
does insurance cover them or not cover? Do you accept insurance? Those kinds of things, and or maybe like Medicare, Medicaid. And I'm just gonna state those. I'm from the insurance world, so that's always a question.
Sure. No, that's a great question and a very important thing that's I'm sure important to your listeners and potential patients. So the short answer is yes. The procedure is covered by all major health insurance plans. Was not the case when I started doing the procedure 23 years ago. It was a very different environment, but the data and how well the procedure worked for many patients became, with any new procedure, there's a trial period where insurance companies consider it to be experimental, but we're well past that now. and it's covered by all major insurance plans. And we're in network with pretty much all the major plans as well, many of the marketplace plans, Medicare, Medicaid. So there are very few things that we don't accept or that we're not in network with. And you're right, so the Fibroid Institute Houston is part of the Fibroid Institute Texas. So I do have colleagues, Dr. Slonim and Dr. Reddy in Dallas, that offer the same procedure, the same, cutting edge pain techniques, pain control techniques, and the same level of expertise in Dallas that we offer here in Houston. And so we do have offices in Dallas and Houston. In Houston specifically, we have clinics in Katy, Sugar Land, Clear Lake, and just opened a clinic in the Woodlands as well. And there are several locations in Dallas. So we try to make it as easy as we can on patients. We offer telehealth visits or televisits. Probably half or so of our new patient consultations are via computer, which really makes it easy and convenient for patients. So we just try to make it as easy as we can and go to the patient and offer clinic time if they want to see us in person in their area of town, and also via computer.
Thank you, doctor. I mean, that makes it a relief for a lot of people that watch and listen now, especially in the Texas area, Dallas and Houston. But I'm assuming if someone from a different state, they may not have access to a similar process or procedure, they can consult with you guys via Zoom or some telehealth, and then ultimately you can book something with them where they can travel down and get it done. But it beats the alternative of not having it done, right? So
absolutely, yeah. We get inquiries from patients out of state, even out of the country, all the time. I know both myself and Dr. Slonim and Reddy in Dallas, the same. Yes, we can certainly treat patients, coordinate patients from out of the state, even out of the country. I know just within the past month or so, I've treated a couple of patients from as far away as Africa who came specifically for the procedure. So it is the vast majority of our patients come, at least in Houston, come from the Southeast Texas area. But I know in Dallas, we get referrals from all over Texas and outside of Texas very, very commonly.
Well, Texas is a pretty big state.
Exactly.
It's the largest, isn't it? So it's got a lot of folks. Yeah.
And I think, this is all that we do. We don't do anything else. We have picked the UFE procedure, which has really been our passion, and we're trying to take it to the next level and do it as well as we can and do it better than we've ever done it before. And so, we're very focused on that. And I think that's a big draw for many patients to know that, these clinics are doing this day in and day out. That's all that they do. And I think that kind of level of expertise and focus on one thing really, I think, goes a long way in providing the best possible care to the patient.
I love it. So, doctor, there's two more things I want to ask because, they tend to always go hand in hand with health, right? One is nutrition and two is exercise and I guess movement. Certainly, the uterus is part of it's in the middle section of the body. And so there is a lot of activity. If you're doing some walking, running, any activity, there's definitely a problem there if you have, severe pain or you have some sort of problem, right? Also, is there any nutritious, advice you can give us in terms of like something that can help, is there such a thing, by the way?
First, exercise. So exercise, is an important part of staying healthy, obviously. And what I've found in terms of how exercise is related to fibroids is I've found that many patients, because of their fibroids, they can't exercise as much or as effectively, especially those that are having the heavy bleeding and they're anemic and their blood counts are low and they get fatigued very easily. They get winded very easily, even young, healthy patients. So it can very much affect a patient's exercise regimen and overall health in those ways. And in terms of nutrition, nutrition is also a very important part of a person's overall well-being and health. There have been some attempts to, attribute certain types of diets to fibroids, or fibroid development or higher risks. And I think there's some validity in some of those claims, but I've never seen like really strong definitive evidence that there's a strong association. So we know the genetic association. There's been some, more recent associations with some of the hair products that's out there that patients have, potentially used in the past. But for the most part, the strongest association is with, genetic and I think obesity and weight. That's kind of indirectly associated with nutrition as well. So that's important as well, because obese patients tend to produce more estrogen, which tends to produce more rapidly grown fibroids and bigger problems. So that can definitely, nutrition works in that way to improve, to increase a patient's symptoms as well.
Healthier nutrition, better health, not obese, therefore less chances. But I love, I think you covered the workout, or like the impact on the gym activity, or the just the fitness part. But on the flip side, once you get a procedure and you get done, I think your life can get better. Therefore, now you can get and resume your activities and become much healthier in all aspects of that matter. So it's actually an important, piece of.
Absolutely, Hurricane. One of the, as I tell patients a lot, there's no way that I could do this procedure day in and day out if it didn't work so well, because it's just so gratifying. And one reason I have such a strong passion for doing it is because it works so well in so many patients and really restores their life. I can't tell you, there's very few things more gratifying than a patient that comes to me, in follow-up a month or so after the procedure, or 2 or 3 months later when we do our routine follow-ups, and says, I can't thank you enough that, I used to plan my entire life around my cycle. I couldn't do things. I couldn't do things with my family. I couldn't, do things with my friends. And you've given me my life back. And it's amazing. That's what makes it all so worthwhile.
Well, there's nothing more than feeling grateful for doing something that is helping others. I mean, I think that feeling is unique in its own. And again, you're doing something with passion that you love and helping others, and that's really sweet. And I love that. That formula is always a success formula.
It is. It's hard. Yeah, it's hard to beat, for sure. I feel very fortunate to be able to do what I do and provide the type of care that we provide.
Well, Doctor, thank you so much. I mean, this has been a great hour. We've covered quite a bit. I know I follow you on Instagram, and you have a whole team, and you guys are very active out there. So how can we get people to connect with you? Where do we send them?
Sure. So our Instagram, since you mentioned it, our Instagram account is Fibroid Free MD. So you can look for Fibroid Free MD. We have a website, which is www.fibroidfree.com. Again, FIBROID free.com. And then our number here in Houston to the Fibroid Institute Houston is 713-903-3733. And, if there's anything we can do to educate, to help, to answer questions, we're always more than happy to accept emails or online inquiries. I think, the website is probably the best place to start with that. There are ways that you can connect directly with us through our website. We have a YouTube channel out there as well with some very educational videos that Doctors Sloanham, Reddy, and myself have done for patients. So it's all part of providing the type of care that we want to provide. But thank you for that. And we're always here for patients if they need us.
All right. Well, listen, I think we have every single way to connect with you and make sure that folks watching, listening, and again, the good news all over the world, because you do have patients from all over the world. Please feel free to reach out to Dr. Fisher and colleagues. And certainly, this is not something. There is one question actually I did not ask. Just hit me. We've talked about the woman, specifically in this particular episode, and women's health. But I mean, there is an impact also with their significant others. Is there any type of, I guess, connection there in terms of when you talk to people? I mean, because sometimes that's going to be part of the discussion. Like, you're going to have to buy in of both parties, right? Do you have that type of discussion that happens? Just to clarify for people, like, because that may be like, what's up?
Yeah, no, I mean, I would say most patients that we consult with are, just the patient, the woman. But many patients, it's not infrequent for them to include their husbands in the consultation, whether that be live, in person, or via the computer or telehealth visit. And because, again, uh, fibroids can have such a dramatic impact on a person's life that it affects everybody around them, their families, their friends. I mean, so it is an important discussion to have, and I think many women want to have that support and emotional and physical support from their spouse or significant other, and we certainly encourage that.
All right. So that's it was bugging me. I forgot about that part.
Sure.
All right. Well, doctor, thank you so much for being with us. And I enjoyed this exchange. I've learned a lot myself, and I know that a lot of people now have all the ingredients to actually know what to do and what to look for and where to go. So I think with that being said, we have the message out there, folks. There you have it. Doctor, thank you so much for being with us today.
Hurricane H, thank you very much for having me. It's been a pleasure. Thank you.
Honor and pleasure here. So, folks, there you have it. We'll be talking soon. New day, new show. I told you guys this was a must watch, and this is the month. So, hey, we're going to spread this word out there. And just look forward to, taking it to the next level. Hopefully, you don't have to deal with fibroid, but if you do, we have a solution. That being said, we'll be talking soon. I'm Hurricane H. Bye for now.